Okay, now let's start with management of status epilepticus. Before that, let's see what status epilepticus. This image is from Marrow. Its definition is prolonged duration of more than 30 minutes. So if a seizure is lasting for more than 30 minutes, it is called as the status epilepticus. It is defined under two time frames, T1 and T2. Let's see. If a seizure is lasting for 5 minutes or more, it is called as the impending status epilepticus. Indicates the time after which the use of anti-epileptics is required to control the seizure. That is, if the seizure is lasting for 5 minutes or more, it will not stop on its own. So then it is called as the impending status epilepticus, and we have to start the anti-epileptics to control the seizure. Second timeline is if a seizure is lasting for 30 minutes or more, then it is known as the established status epilepticus, and there is high risk of developing neurological sequelae. In this established status epilepticus, that is after 30 minutes. Management: in the first 5 minutes of any seizure, there is no need of anti-epileptics. Just do the precautionary things like tilt to the left lateral side of the patient and remove any sharp objects around the patient, place him in a safe place so that he or she doesn't injure themselves. Now let's start with the management. These notes are prepared from Suchitra Ranji. Status epilepticus. On presentation to hospital, we have to support the airway, breathing and circulation, the basic that we do. Now, if the seizures are unabated at 5 minutes, that is still present after 5 minutes, then the first line drug are lorazepam and midazolam. Lorazepam is preferred one because it causes less respiratory depression as compared to midazolam, but both can be used whatever is present at your hospital. Lorazepam is given in a dose of 0.1 mg per kg and maximum 4 mg can be given. Can repeat 10 minutely up to 3 doses. So we can repeat lorazepam up to 3 doses every 10 minutes. Midazolam can be given if IV access is not being obtained while the patient is in seizure. It is hard to obtain an IV access, so we can give IM also midazolam in the dose of 0.2 mg per kg, and if IV access is obtained, then 0.1 mg per kg. Okay, if we are giving IM in an emergency, 0.2, remember that, 0.2 mg per kg if no IV access. Right, we can again give 3 doses of this midazolam every 10 minutes and maximum single dose is 5 mg. Benzodiazepine are the fastest drug to stop the seizures. Okay, so that's why they are the first line. Now coming to the second line drugs. First drug is fosphenytoin, then levetiracetam or IV valproate, and then phenobarbital. That is PLP. We can remember like that. PLP. P for phenytoin, L for levetiracetam, and again P for phenobarbital. Fosphenytoin is given in a dose of 30 mg per kg. IV, maximum 1 gram can be given. It is diluted in NS over 10 minutes along with second dose lorazepam. Okay, we have to dilute the fosphenytoin, that 30 mg per kg in NS over 10 minutes. Okay, then may repeat if we want to repeat the dose of fosphenytoin. If the seizure is still not stopped, then we can repeat at the dose of 15 mg per kg fosphenytoin if seizure persists. Okay, and this is an equivalent of fosphenytoin and phenytoin. That is 1.5 mg of fosphenytoin is equal to 1 mg of phenytoin if phenytoin is present at your hospital. Then after 20 minutes, if the seizure still persists after giving fosphenytoin, 20 minutes even after fosphenytoin seizure persists, then we have to give levetiracetam or IV valproate. Both are in the same dose, and even phenobarbital is in the same dose, 20 mg per kg. Even phenytoin is in the same dose. If you give, it's again 20 mg per kg, but because here we have written fosphenytoin, that's why it's 30, otherwise it was also 20. So it's easier to remember that all the second line drugs are in the 20 mg per kg dose. And if we are giving levetiracetam or IV valproate, we have to give at 5 mg per kg per minute. Okay, it is also given over 10 to 15 minutes, diluted in NS or 5% DNS, and IV valproate same, given over 5 to 10 minutes, dilution in NS or 5% dextrose. And after 40 minutes of onset, this is not from giving levetiracetam or IV valproate. It is after, I think, this fosphenytoin to levetiracetam is also after 20 minutes. It's from the onset itself. Sorry for that. After 40 minutes of onset, if the seizure still persists after giving levetiracetam and valproate, also we have to give phenobarbital again in the dose of 20 mg per kg, but at a rate of 2 mg per kg per minute, and we can repeat the dose of phenobarbital also with 10 mg per kg if the seizure persists. And if seizure persists after giving phenobarbital, then it is termed as, not after giving phenobarbital, but after giving all the second line drugs that we read, like fosphenytoin, levetiracetam, IV valproate and phenobarbital, then it is termed as refractory status epilepticus. And in case of refractory status epilepticus, we have to give continuous infusion. So we can give continuous infusion of midazolam or phenobarbital or thiopentone. Okay, let's start with midazolam infusion. We have to give initially bolus 0.15 mg per kg. How much we were giving initially? It was, midazolam was 0.2, right? 0.2 IM and 0.1 IV. But in bolus form, if RSE is confirmed, that is refractory status epilepticus is confirmed, we have to give midazolam in 0.15 mg per kg bolus, then 2 microgram per kg per minute infusion. Okay, if seizure persists, repeat 0.15 mg per kg bolus and increase the infusion rate by 2 microgram per kg per minute as needed, and maximum we can give 24 microgram per kg per minute or 20 mg per hour. Okay, now after giving midazolam also the seizure persists, then consider multiple doses of phenobarbital 10 mg per kg say, irrespective of the serum levels. And if seizure still persists, we can give thiopentone infusion 4 mg per kg, then 1 to 6 mg per kg per hour with EEG monitoring. Consider giving pyridoxine 100 mg IV push if less than 18 months. Okay, pyridoxine, we have to give pyridoxine. You know, pyridoxine is given in infants because in status epilepticus there is something called pyridoxine dependent epilepsy. So if it is reaching up to the state of refractory status epilepticus, we have to consider it as a possibility, and it is a reversible cause of refractory seizure also, because there is something called vitamin B6. This pyridoxine is required for GABA synthesis, so its deficiency leads to decreased inhibitory neurotransmitter, so the seizure persists. So giving pyridoxine can rapidly stop the seizure, and it is both diagnostic and therapeutic. Okay, now let's move further. This was all up to the management. Last step was thiopentone infusion, and there was something extra given here. It's again a image from marrow. Refractory status epilepticus, seizure persisting after that second line medication, and we give a barbiturate coma is induced with a continuous infusion of either midazolam, thiopentone and phenobarbital. We read that. If the seizure persists, then it is called as the super refractory seizure. We saw it up till refractory status epilepticus. This is super refractory status epilepticus, and in the end we give ketamine infusion or IV immunoglobulin. Okay, now these are just some points that we should know. When we have to do early referral of the PICU, if any of the following is present: airway, ventilation, cardiovascular compromise is present, then we have to refer to PICU. Seizure refractory to second line medication, then seizure lasting for more than 30 minutes, and need for midazolam or thiopentone infusion. Okay, midazolam infusion, what we have to monitor and what we have to keep in mind is monitor the ABC, may need intubation, ventilation and pressure support. Consider arterial BP monitoring. Consider EEG, at least BD. Okay, and if no seizure, clinical or EEG for 24 hours, wean by 1 microgram per kg per minute. In infusion, how we were giving midazolam by 2 microgram, and if the seizure was persisting, we were increasing the infusion rate by 2 microgram, that is to 4 microgram then. So we have to monitor, and if seizure was not present for 24 hours, then we can wean by 1 microgram per kg per minute. If the seizure reoccur, consider previous midazolam infusion with every 2 hourly rate that achieve burst suppression patterns. Stop the midazolam infusion once the thiopentone is started. Refractory status epilepticus. If the status epilepticus is lasting for more than 60 minutes, then it is called as refractory status epilepticus. Okay. Despite the optimal therapy with the first and the second line drugs that were benzodiazepines and phenytoin and that levetiracetam, IV valproate and phenobarbital may be defined as the refractory status epilepticus. Rate of administration of the drug is more important in status epilepticus than the total dose administered. Okay. And broad spectrum high dose antibiotics and acyclovir should be administered empirically to patients who present with new onset status epilepticus and fever. Why? Because we are suspecting any infection that can cause this, like meningitis, so we are giving antibiotics, and encephalitis caused by viral encephalitis, so we are giving acyclovir because the patient is presenting with fever that somehow indicates that infection might be present. Empirical antimalarials may be considered if cerebral malaria is considered possible. So this was all about the management of status epilepticus. Hope you liked it. Thank you.